picture a really brilliant epidemiologist. We are talking about someone with, 20 years of gritty field experience.
Right, a total veteran.
Exactly. Someone who has actively contained Ebola outbreaks
Yeah.
and practically wrote the definitive textbook on disease surveillance. They are an absolute rock star in their field.
Oh, absolutely.
But then they sit down for a 45-minute interview for a senior director role at the World Health Organization, and they just completely bomb it.
Yeah, it happens all the time.
You can almost feel the energy drain from the room, and within 10 minutes, the panel has already, mentally moved on.
Right.
Why does that happen? I mean, have you ever wondered how someone so undeniably qualified can fail so spectacularly in that specific environment?
It is honestly one of the most frustrating paradoxes in public health recruitment. You would naturally assume that supreme technical competence is just, well, a guaranteed ticket to the top.
Right. You'd think so.
But having sat on the other side of that table for the WHO, UN agencies, and, various ministries of health, I can tell you it is a phenomenon I have seen more times than I can count.
Wow.
We see these absolute titans of medicine walk in, and they just fundamentally misunderstand the assignment.
So if you are navigating that transition right now, or even just aiming for a senior leadership role in your future, you are in the exact right place. Welcome to today's deep dive.
Glad to be here.
We are exploring a really highly specific, fascinating source today. It's the Public Health Leadership Interview Simulator. It is a 160-page premium workbook created by Dr. Oussama Wail Bouhentala. He's a physician epidemiologist, and it's published by Boughteen Publications.
And we should probably clarify up front, this is not your standard run-of-the-mill list of corporate interview tips.
Definitely not.
This is a highly rigorous, specialized manual designed specifically for senior public health leadership interviews. I mean, it contains 4-round escalating scenarios, complex scoring grids, and even AI mock interview prompts to, really simulate the pressure of a real panel.
Exactly. And in my career coaching practice, I spend all day helping brilliant executives get out of their own way and stop making unforced errors during career transitions.
Which is so common.
It really is. And I see the exact same bottlenecks in standard corporate leadership that this workbook highlights in global health. But you bring the perfect insider perspective to this, having actually been the person holding the grading rubric for those global health organizations.
I have filled out those exact rubrics. I know the exact moment a candidate loses the confidence of the panel. And I also know the incredibly rare moments when a candidate manages to completely command the room and shift the entire dynamic of the conversation.
So our mission today is critical. We are going to uncover the exact structural reasons why senior candidates fail these interviews, and we are going to break down the specific framework you need to actually pass. Okay, let's unpack this, because the first major revelation in this workbook, what the author calls the technical trap, well, it completely flips how most people think about their interview preparation.
It really does. To understand how to pass, we first have to establish why so many fiercely qualified people fail. The core philosophy here is that when panels at the WHO or a Ministry of Health are interviewing you for a senior role, they are absolutely not testing your textbook knowledge.
Wait, really? Not at all?
No, senior interviews do not test what you know. They test how you lead when you don't know the answer.
Wait, I mean, I have to challenge that a little bit. If I'm hiring a chief epidemiologist or a regional director of health, I absolutely care about their clinical and medical knowledge.
Sure.
Like if they misdiagnose the pathogen or if they don't understand the etiology of the disease, the leadership framework doesn't matter, right? You're saying panels just gloss over the actual science.
Not at all. It is not that they gloss over the science. It's that the science is simply the price of entry.
Oh, I see.
Yeah, if your CV made it past the initial screening and you were sitting in that interview chair, the panel just assumes you know your case definitions. They assume you know the routine vaccination schedules and the basic epidemiology.
Makes sense.
Candidates fail because they confuse a technical answer with a leadership answer. When faced with a complex scenario, they retreat into the comfort zone of their technical expertise.
It sounds like a master chef taking an exam.
Ugh.
The panel isn't watching to see if you know how to chop an onion. They are watching what you do when the stove catches fire and half your staff walks out.
Yes, that is a perfect analogy. Weak candidates describe what should happen in a perfectly functioning ideal world. They quote standard guidelines.
Right, the textbook answer.
Exactly. They say they would wait for laboratory confirmation or wait for official permission from the ministry before taking action. But in a real disease outbreak or a massive budget shortfall, the textbook does not give you a clean answer. What's fascinating here is that the gap between passing and failing is rarely technical. It is structural.
Structural, okay.
Strong candidates demonstrate judgment under extreme uncertainty, and they prioritize ruthlessly when resources are constrained.
Look, it's one thing to say candidates need to show leadership or good judgment, but those are highly subjective terms. How does a panel of rigorous global health experts actually quantify that subjectivity on a grading sheet?
That's the million-dollar question.
Because the workbook clearly outlines 5 hidden competencies that panels are evaluating on a strict scale of 1 to 5. Let's look at how candidates actually fail or pass these specific metrics, starting with decision-making.
Right. So a level 1 or level 2 candidate on decision-making is the person who waits for perfect data.
Which you never have in a crisis.
Exactly. But a level 5 candidate understands that acting under uncertainty requires a principled framework. To score a 5, you have to prove you can act on the worst plausible diagnosis when a delay would cost lives.
So you have to be bold.
Bold, but calculated. You make your underlying values explicit to the panel, and you do not wait for permission to initiate life-saving protocols.
Which naturally requires you to explain that rationale clearly to the panel, which brings in the second competency, structured communication. And I see executives fail this all the time.
Oh, I bet.
They are so eager to prove how smart they are that they just bury the panel in caveats, jargon, and meandering background context.
Yes, the academic urge to explain every single variable.
Exactly.
A level 5 in structured communication means delivering sequenced, accessible information that holds the room's attention. But it is more than just being articulate. You have to calibrate to your audience by balancing intense technical precision with genuine human warmth.
That's a tricky balance.
It is, but you are dealing with human lives. If you sound like an algorithm, the panel will not trust you to lead people.
That balance is critical, especially when we consider the third competency, leadership and stakeholder management. In a standard corporate hierarchy, you could often just, fire people who don't listen to you.
Right.
But in global health, you are dealing with sovereign ministries of health, competing NGOs, and local community leaders.
Exactly. You cannot just boss around your direct subordinates. A level 5 leader aligns people who do not report to them.
That's so much harder.
It's incredibly hard. It is about managing intense political and social opposition to build durable institutional architecture. You have to influence people who have absolutely no obligation to listen to you.
That is the ultimate test of soft power. But even with everyone aligned, these environments are inherently chaotic, which leads to the fourth competency, crisis and risk management. The workbook highlights something really profound here. It isn't just about spotting system-level risks or anticipating second-order effects. It emphasizes knowing what to stop.
That is the most common failure point for this competency.
Really, knowing what to stop.
Yes. Let me give you a rapid-fire example. Imagine a candidate is managing a severe cholera outbreak. They implement a new digital tracking system, which is great.
Sure.
But they fail to stop the legacy paper-based reporting system. Now, an already exhaustive field staff is doing double data entry, critical data is delayed by 48 hours, and that bottleneck costs lives.
Oh, wow. I would have even thought of that.
Most don't. A level 5 candidate explicitly tells the panel, "Here's the redundant program I am shutting down immediately to free up operational bandwidth."
That is true prioritization. Everyone wants to add to a crisis plan, but taking things away requires real courage.
It does.
And the final grading metric is measurable outcomes. I'm assuming things got better. Doesn't cut it for a level 5.
Not even close. You cannot make aspirational claims. A level 5 answer uses highly specific indicators, precise targets, and strict timeframes. Furthermore, those outcomes need to be embedded into routine surveillance with sustained accountability. You have to prove how you will measure success.
So we have decision-making, structured communication, stakeholder management, crisis management, and measurable outcomes.
That's the 5.
And the workbook explicitly notes that average candidates might accidentally hit 1 or 2 of these competencies simply by rambling long enough. But a truly strong senior candidate addresses all 5 of them intentionally in every single answer.
Every time. They do not leave it to chance.
Okay, but it is easy to sit here and list the competencies. Delivering them in a 5-minute answer under the glaring lights of an interview panel without losing your train of thought, that sounds incredibly difficult. How do you actually structure that answer?
You need a mental architecture, and this is where the workbook introduces the core framework you must use. STAR+PH.
Okay, let's deconstruct that. Most people listening who have prepped for any job interview have heard of the standard SCAR method. Situation, task, action, result. It's the classic behavioral interview framework.
It is, but the author, Dr. Bouhentala, makes it very clear that standard STAR is completely insufficient for senior public health roles.
Insufficient. Why?
Because STAR was designed for middle management. It proves you can execute a task, but senior roles require you to prove you can design the task and fix the system.
So how do we optimize it? Let's walk through the mechanics of the upgrade, starting with situation.
For situation, the rule is strict. 2 to 3 sentences maximum.
Wow, that's short.
It has to be. Most candidates waste up to 40% of their allotted time here, lecturing the panel on the history of the disease or the geography of the region. It should only be 15% of your answer. Just establish the environment, the stakes, and the primary constraints.
Keep it incredibly tight. Okay, then task.
Task is your specific mandate. Not what the broader organization was doing, but what you are uniquely responsible for, stated in 1 or 2 sentences.
Got it. Then action, which has to be the meat of the answer.
It is. You sequence your actions chronologically, but you must name your trade-offs. You explain why you chose path A over path B, and you explicitly state what you stopped doing to manage risk.
There's that stopping piece again.
Exactly. This is where you demonstrate those decision-making and risk management competencies we just discussed.
And then result, which ties back to the measurable outcomes competency. Strict timeframes, hard data. But here's where it gets really interesting. The workbook adds this game-changing element, the +PH, which stands for public health reflection.
Yes. The +PH is the entire difference between an average candidate and a senior executive. It is a structured, intentional closing that connects your tactical, boots-on-the-ground answer back to high-level systemic implications.
Yeah.
It addresses future preparedness, health equity, or institutional learning.
So standard STAR is just putting out the fire. But the +PH is taking the time to install a sprinkler system so the building never catches fire again.
That is the exact mental shift panels are desperately waiting to see. They want to know, what did this crisis teach you about the underlying fragility of your system?
Right.
What structural change did you implement so that our organization never has to fight this exact same fire again? Average candidates stop at the immediate results. Senior practitioners always offer the structural reflection.
Let's take this framework out of the theoretical and apply it to a real high-pressure scenario. Because the workbook contains 20 flagship simulations, right?
Okay.
Let's look at the measles outbreak scenario to see how this plays out in practice.
Let's do it.
Okay, I am going to read the brief. If you are sitting in the interview chair, you get about 90 seconds to process this information before you have to speak. So here is the scenario. You are a district medical officer responsible for the public health of 400,000 people. Over the past 3 weeks, there have been 47 reported measles cases. For context, last year there were only 4 cases all year.
So we are looking at a severe acute spike.
Exactly. Furthermore, your vaccination coverage data from 18 months ago shows coverage at only 68%, which is well below the 95% threshold required for herd immunity. 3 children are currently hospitalized with severe complications, including pneumonia and encephalitis.
That's grim.
Yeah, it's intense. Now, here are your operational constraints. Your district's vaccine cold chain is highly unreliable. You have absolutely no spare workforce. Your staff is maxed out. And finally, your district includes a religious minority community with significant entrenched vaccine hesitancy. The panel looks at you and asks, you have just been notified of this cluster. What do you do in the first 72 hours?
That is a masterfully written brief. It is realistic, it is terrifying, and it contains just enough missing information to truly test a candidate's judgment under pressure.
Okay, I'm going to give you the weak answer that the workbook highlights. Tell me why this candidate fails. They say, I would inform the regional health authority, activate the outbreak response plan, and immediately begin a mass vaccination campaign across the district.
Yes, that is the classic reflexive answer. To a layperson, it sounds decisive and appropriate. To a WHO panel, it is an immediate, catastrophic fail.
Break down exactly why.
Well, first, they ignored basic causality. They skipped the epidemiological investigation entirely. You cannot just launch a massive campaign when you don't know the index case, the source, or the chain of transmission. You are essentially flying blind.
And they completely ignored the constraints provided in the brief.
Exactly. The brief explicitly warned you that the cold chain is unreliable. If you reflexively launch a district-wide campaign without auditing the refrigeration logistics first, you are going to administer spoiled, thermally degraded vaccines to thousands of people.
Oh, man, yeah.
You waste precious resources, you fail to stop the outbreak, and you permanently destroy public trust.
Not to mention, they didn't even mention the hospitalized children or the hesitant minority community. It is a generic copy-paste answer.
Completely. Now, let's build the level 5 response using the STAR+PH structure. For your situation and task, you keep it to 15%. You quickly synthesize the constraints back to the panel: 47 cases, 68% background coverage, compromised cold chain, and a hesitant community.
Okay.
Your stated task is to confirm the outbreak, halt transmission, and navigate those logistical constraints within a 72-hour window.
The setup is tight. It proves you listened. Let's move to the action. The workbook breaks this down into strict operational timelines. Hours 0 to 6. What is the move?
In hours 0 to 6, you establish a firm case definition and you map the 47 cases by geographic location and vaccination status. That data map directs your entire response.
Makes sense.
Simultaneously, your first physical action is to ensure the hospitalized children are receiving appropriate clinical care or being escalated to a regional facility. You protect the most vulnerable first.
You are hitting the decision-making competency right there, acting decisively with a framework. What about hours 6 to 24?
This is where you prove your risk management and your ability to handle constraints. You explicitly tell the panel that you will audit the cold chain before moving a single vial of vaccine. If the logistics are broken, you fix them first.
Right.
Then, instead of a massive wasteful district campaign, you use your data map to initiate ring vaccination. Vaccinating only the direct contacts and immediate neighbors of confirmed cases, you save resources and you move faster.
That is knowing what to stop. You stop the blanket campaign. Then hours 24 to 72, you still have this hesitant minority community to deal with.
Here is your stakeholder management. You do not send government doctors in white coats to demand compliance. You engage that hesitant community through trusted intermediaries like religious leaders or local community health workers before the vaccination teams arrive.
All right.
Finally, you send a highly structured situation report to the regional authority, not just saying, we have a problem, but asking for specific, targeted support, like deploying a field epidemiologist.
The actions are beautifully sequenced. We move to the result.
Mm-hmm.
And based on our earlier discussion, you don't just say we managed the outbreak.
You provide a strict, measurable outcome. You tell the panel the target is 0 new cases from unvaccinated contacts within a 14-day incubation period.
But we aren't done. The candidate has survived the crisis. Now they have to deliver the closing strike, the plus pH reflection, the structural fix to the water supply.
If we connect this to the bigger picture, the truly senior candidate pauses, looks at the panel, and says, a coverage rate of 68% is not a surprise. We knew this from the data survey 18 months ago. Therefore, this measles outbreak was not an anomaly. It was entirely predictable.
Wow. They're pointing out the systemic institutional failure.
Right. The candidate concludes by saying, the structural question is why that 68% data point did not trigger a proactive catch-up campaign a year ago. After the acute response is stabilized, I would initiate a root cause review of our surveillance to action pathway. I would use the political leverage generated by this crisis to secure permanent funding for a sustained, community-led vaccination program, so this district never faces a preventable outbreak again.
That's a profound perspective shift. You're moving the burden of the crisis from the tactical responder to the structural architects. I can clearly see why panels are actively looking for that level of thinking. You seamlessly demonstrated all 5 hidden competencies without ever explicitly listing them.
And that is exactly what separates a mid-level technical expert from a senior structural leader. In that answer, you didn't just rattle off pediatric medical facts about measles. You navigated complex human behavior, you managed supply chain logistics, you understood political leverage, and you proposed systemic reform, all while keeping the clinical reality of those 3 hospitalized children at the very center of your response.
So what does this all mean? As we wrap up today's deep dive into the Public Health Leadership Interview Simulator, the overarching takeaway from all 160 pages, the scoring rubrics, and the frameworks is undeniable. Advancing to senior leadership is fundamentally a mental shift.
It really is.
You have to start trying to prove you have memorized the textbook and start proving you know how to build, navigate, and fix the system.
It is about demonstrating to a skeptical panel that you can hold the immense complexity of a crisis in your hands without dropping the human element, the political reality, or the structural necessity.
Which brings us right back to that incredibly smart brilliant epidemiologist we talked about at the very beginning of the show, the one who keeps failing the interview. They aren't failing because they lack intelligence or experience. They are failing because they are answering the wrong question. They're stuck in the technical trap.
But once you understand the architecture of a strong answer, once you see the mechanics of STAR plus PH, you can't unsee it. It changes how you approach every professional challenge.
I want to leave you with a final thought to mull over. Think about a recurring crisis, a bottleneck, or a constant frustration in your own daily work right now. Are you currently just applying standard STAR actions, just putting out the exact same fire week after week, surviving the crisis? What would happen if you applied a plus pH mindset tomorrow morning? What structural change could you demand? Or what system could you implement so that you never have to deal with that exact same problem ever again? Think about that. Until next time.